Our final speaker today is Dr. Hugo Martinez. He is visiting us today from Memphis, Tennessee. He is an associate professor of pediatric cardiology and genetics at the University of Tennessee and is part of the Cardio-Oncology service that manages patients both at Le Bonheur Children's Hospital and St. Jude Children's Research Hospital. And he's here today to speak to us about cardioprotective strategies in oncology.
Thank you. All right, there we go. So first of all, thanks for the kind introduction. Thank you for the organizers for allowing me to participate in this amazing symposium. And thank you to all of you for supporting us today with your presence. I don't have any financial disclosures, unfortunately. And and as Dr. Harris said, so I am relocating my family, and I am moving my clinical and educational and academic practices to Austin. So it's an exciting time for me. I wanted to share. The objectives of the three main objectives of my presentation include I will be briefly describing the connection between cancer therapies and the development of CTRCD. So I'm going to be talking a lot about these concepts. So it's cardiac therapy related, cardiovascular diseases. And this is nothing but an umbrella term that encompasses or incorporates not just cardiotoxicity, but all these different diseases that we see along the pathway of cancer therapies. I am also going to discuss and elaborate on the clinical framework of this CTRCD. There are a ton of new cancer medications almost every other day, and it would be impossible for me to go through all of them. So what I will do is I'm going to give you essentially one or two frameworks in how to integrate all these cardiovascular diseases and cancer so you can apply that to essentially any drug that you can see when managing our patients. I will apply also that framework into the use of anthracyclines. I think that regardless of what type of practitioners we are, oncologists, primary care physicians, cardiologists, nephrologists, et cetera, I think we all at some point are going to cross this intersection of anthracyclines and adversity. And then finally, the last topic of my presentation, I'm going to be touching base towards the last part of this talk, and I will cover some of the academic research activities that I've been participating in within the field of cardio-oncology. All right, I thought about starting off with a case report. So this is a 5-year-old girl with Down syndrome and AML. She received chemotherapy and developed cardiac dysfunction soon after starting therapies. We were very fortunate to support her cardiac function throughout her cancer therapies, and she made it through remission, and why not? Unfortunately, her cardiac dysfunction worsened to the point that her heart failure was refractory to any medical therapies. She required eventually the implantation of a ventricular assist device, so that's one of my specialties, the monitoring and the functional aspect of mechanical circulatory support. So we implanted an artificial heart, essentially, just to keep up with her circulation. And eventually, we deemed her a candidate for cardiac transplantation. So we underwent that pathway. There we go. With this illustration at the top of your screen, I'm going to show you this cartoon that delineates what's a normal and an abnormal heart. So on the left side, we have a normal anatomy, 4 chambers. On the right side, you have the color blue for the right-sided heart. And on the left, you see the other 2 chambers, left atrium, left ventricle. In contrast to the picture of the right, where you see a very dilated left-sided heart, you see the globular appearance of the left ventricle at the bottom side of the right-sided place, the left-sided place on red. And you see distortion of the mitral valve and also dilatation of the left atrium. So if I try to show you these in a live video clip from an echocardiogram, this is her baseline echo. And what you see here is a very robust squeeze and a very robust relaxation of her heart. So I would consider this normal, in contrast to a very globular, dysfunctional, very dyskinetic. So some areas contract, some other areas don't contract as well. And you see in the middle of the heart a lot of gray smoke, and we call that spontaneous contrast. And what it means really is that the blood flow is so sluggish that creates a lot of stagnation, and so the blood flow doesn't really go to all the body components. So what we decided to do with this particular case is we implanted, like in many patients that progress to the end stage and refractory cardiac disease, we implanted left ventricular assist device. So we actually use the one in pink right in the middle of your screen. It's called a hardware LVAD. We actually don't have it in the market anymore, but use that to bridge her stage to transplantation. And so I think that with this figure on the left, essentially I'm just representing from a 3D reconstruction of a CT scan, one of her CT scans of the chest. And as you can see, we have the ventricular assist device implanted at the apex of the left ventricle. And what it does is that with the inflow, it essentially sucks the blood out of the heart, and it sends it through the outflow to the aorta so she can have normal and regular activities. This device goes inside of the chest, and patients can go and resume daily activities. With this case, I'm just showing you the worst case scenario in the spectrum of cardiotoxicity. This scenario also displays how an interdisciplinary team, an interdisciplinary approach changes patient care and outcome. I would like to highlight the importance of establishing avenues of communication between oncologists and cardiologists, because on one side we have the oncology team willing and really trying to do the best for these patients to get rid of leukemia or any other some sort of cancers. And on the other side, we have my cardiology team supporting and trying to balance the adversity from all of these therapies. So cardio-oncology is really a lot of that when it comes to when to push forward and keep moving with these patients when it comes to the management of cancer and promote and provide more cancer therapies. Cardio-onc is a lot of discussion with the oncology teams on when to back off or when to offer alternative treatments and ultimately palliative care. And that's a lot of the practice that we do in our hospitals. Let's see. All right, so the way I tailored this particular talk is by incorporating some of the paradigms or statements or thoughts that I've actually heard throughout these years of practice walking around the hospital in a day-to-day practice. So what I'm gonna do is that I'm gonna go into present some of these statements or thoughts that I've heard from other people, and then I will introduce you with some arguments that hopefully will convince you to believe that we have entered a new frontier in the management of cardiovascular diseases for cancer patients. So here's the first one. Cancer patients are not going to do well, so we don't need to worry about the heart or the cardiovascular health. And so, false. I do believe that due to innovations in cancer therapy, you know this better than me, the survival has significantly increased compared to decades ago. The cardiovascular disease, though, remains one of the leading causes of morbidity and mortality in these particular patients. So I do believe that it's in our best interest to provide an adequate prevention and timely treatment of cardiovascular diseases to improve the outcome in this particular and vulnerable patient population. Let's see. So from a variety of references, we do know that children with cancer are somewhere in between 5 to 15 times more likely to develop cardiotoxicity. And although most of these publications and studies have actually focused more into the long-term effects, I do believe that the subclinical, so the asymptomatic patients, the asymptomatic toxicity is quite prevalent amongst our patient population. And it has been reported, again, across many different studies, in about 30 to 60%. So 30 to 60% of the oncology service patients are going to have some degree of cardiotoxicity in the asymptomatic phase, so not developing symptoms. And on those patients developing frank signs of heart failure or becoming very symptomatic, we have somewhere in between 5 to 15% of patients developing heart failure while undergoing cardiac therapies. So it's not that uncommon, in my opinion. The good news is that the diagnostic rate, the way we are diagnosing these patients, whether it's symptomatic or asymptomatic, it's increasing. And that is mainly due to the incorporation of advanced cardiac imaging modalities and other surrogates to test for cardiotoxicity. The bad news, though, is that when we do see patients in the severe spectrum of the disease, so patients who have developed severe cardiac dysfunction, those patients have a significant increase in mortality, up to tenfold. So they do die. And this is something that was summarized in the conclusion of this particular study out of Europe, where they incorporated more than 800 patients, 865 patients or so. And they divided all these patients who underwent cardiac cancer therapies into four main different groups. So we have the no toxicity, the mild toxicity, the severe toxicity, and the moderate toxicity. And so presumably, what this pie chart displays is that about 40% of the cohort developed cardiotoxicity. And this was diagnosed by biomarkers and by the inclusion of advanced imaging modalities to delineate the cardiac function. So presumably, due to an early detection in the management with appropriate time, most of the patients remain in the mild spectrum of the disease. And only about 2 to 3% of these patients progress to the moderate and or the severe spectrum, respectively. So once again, I think it's very important to highlight that those patients with advanced cardiac disease, those patients in the severe spectrum, and this is a very short follow-up time, so only for 24 months. So I would say that this is a subacute toxicity. These patients have a tenfold increase in mortality when compared to those patients in the mild group. So for those that we diagnose, I think it's better to diagnose them timely and to deploy adequate medication so we can mitigate the severe spectrum of this disease. Now, relatively similar numbers. Here at St. Jude, what we've done is our consulting service provides somewhere around 1,200 clinic consults a year, 6,000 echoes, and about 8,000 EKGs. So that just tells you that we really monitor our patients a lot. The primary diagnosis from these consults, when we trace them down by the primary diagnosis from 2017 to 2019, are listed here in this particular slide in order of frequency. So please note that the most common diagnosis that we dealt with, and this is the diagnosis assigned by a cardiologist. So the primary diagnosis from all these consults, about 2,500 consults, was a diastolic dysfunction. Not to get too technical, but every single cardiac cycle, every single beat typically comes in two main phases. So the diastolic phase, when the heart relaxes and accommodates blood, and the systolic phase, where the heart squeezes and sends the blood out. So those two phases can be impaired, and not surprising because data has suggested that the vast majority of the cardiac phase that gets affected on patients undergoing cardiac therapies is diastolic dysfunction. So it's the impaired relaxation. The heart doesn't accommodate blood, so it doesn't matter if it has a good squeeze. The amount of blood that has received is not adequate. So the diastolic dysfunction, in my opinion, and in my experience, I do believe is related to volume overload, endothelial dysfunction, and myocardial inflammation. The second most common diagnosis is tachyarrhythmia. So whether it's just the regular sinus tachycardia, but at a higher speed, sustained, or the development of abnormal or pathological arrhythmias. And then the third most, this topic is important because we published 2021, 2020, and we followed patients with under the BMT service for the past 5 years or so. And so what we notice is that those patients who have been diagnosed with persistent tachycardia have a significant correlation with cardiac dysfunction. The third most common diagnosis is systolic dysfunction. This is the one that most people put attention to, though it's not the most common one. This is something worth to mention. The systolic dysfunction is that one diagnosed by looking at a given ejection fraction, and when it's low, we think that the patient has cardiac dysfunction. I think that, in my opinion, the overall good news in this particular statistic is that the vast majority of patients with diastolic dysfunction and impaired relaxation, they do well, and most of them, they don't have problems with it. Contrary to those diagnosed with systolic dysfunction or an affected ejection fraction, that we've seen that 3 to 5% or so undergo to the moderate to the severe spectrum of the disease. And one of the examples that I mentioned at the beginning with my case report is that we are ready to support. I think that the mantra from the cardiologist should be that we should provide support to the therapies that you guys are providing to your patients, rather than having the mantra of prohibiting and saying no more. Patients undergoing cancer therapies, again, we do know now that can experience heart failure. But I do believe that the manifestation of heart failure may represent just the tip of the iceberg, comprising a wide spectrum of cardiovascular, clinical, and subclinical diseases. In most oncology practices, and this is across the country and the globe, in most oncology practice, what we've seen is that the cardiology team gets to be involved only when the signs or the symptoms of cardiac disease become evident to non-cardiology practitioners. And I think that by practicing that way, we're a little bit behind on the game. So what we elaborated at St. Jude, we adopted a little bit of a different approach. So we have what we call a frontline service, where we have are doing around service rounds with the intensive care unit. When they have oncology patients, we are chatting on a daily basis and seeing the patients with the BMT service, with the leukemia service, and so forth. And so I do believe that that particular approach gives us the enormous opportunity to diagnose under the eyes of the cardiology team, rather than waiting when sometimes the evidence of these diseases are too late or too advanced. All right. Second challenge. Cardiac issues in cancer patients are, all these issues are a down the road problem. So let's get them through their cancer treatments, and we can worry about the heart later. I got mad when I listened to that. So, this is another statement or thought or paradigm that I overheard while rounding one of these days. And so, false. Many cancer therapies are associated with acute cardiovascular diseases. So I showed you some of the information about it. And again, this is the mantra of having a cardiology team that it's supportive. Have that thought process of, I'm gonna get your patients through, because we have not an arsenal like you have, but we have some medications orally or intravascularly, or even these machines that we sometimes implant so the patients can complete their therapies. And, cardiology and oncology should not compete. I think that there should be some sort of a balance, a yin-yang, where opening venues of communication are not going to have anything else but mitigating morbidity and mortality. So what are the risk factors for CTRCD? The risk factors to develop vascular or cardiac toxicity may be determined by, I want to talk to you about two main factors. So one is the bioprofile of the patients per se. And I think that's related to the domains of the cancer, the domains associated with the cancer, the nature of the therapies for these particular cancers, the cardiovascular reserve at baseline and through these therapies, and how optimal or not are the functions of other organs and systems. And although the other point that I want to discuss that generates a risk factor to be late in the diagnosis of cardiotoxicity is that although many chemo or radio or BMT protocols include some sort of level of screening at baseline and during these treatments, many of these protocols continue to use methodologies such as the shortening fraction that, that are not quite accurate. I do think that these protocols and surveillance are running behind and not integrating novel imaging modalities to assess cardiac function and cardiotoxicity in the pediatric population. So briefly, not to get too technical, shortening fraction or fractional shortening is a very poor measure of left ventricular systolic function. That was designed back in the 1980s, and soon after, in the beginning of the 1990s, the Heart Failure Society of America said this is not helpful. So we're talking about decades that in my particular practice, advanced cardiac therapies, cardiomyopathy, haven't used shortening fraction. Not that I've been practicing for 3-4 decades, but we haven't used it. I actually don't know the normal range and the value of it. But so there are two main reasons why we don't like shortening fraction. Number one, and this is the lessons that we've learned, the left ventricular geometry must be normal to come up with a calculation of it. And there must not be any regional or segmental differences in the contractility or the function of the heart. So let me play this one here. And so in this patient population, the geometry is abnormal, the geometry of the left ventricle, because some areas are more swollen than other ones. Some areas have developed fibrosis, or not the whole contour of the left ventricle is normal, and therefore the contractility by different segments is affected. And I'm just gonna play this video to show you that if we're measuring at the tip of the heart, and if we're measuring the shortening fraction in the mid segment, and if we're measuring the shortening fraction at the top of the heart, we're gonna face significant differences on how that particular heart is doing. Okay. So the two imaging modalities I thought about talking to you was a cardiac MRI and so this particular one, strain analysis. It was going to be a lot, and I don't want to overwhelm you, especially because I'm at the end of the symposium. So I'm just going to talk about the imaging modality or strain analysis. This is relatively new, though in adults it's been ongoing for about 2 decades. But this technique analyzes multiple myocardial segments through speckles. And think about these speckles like the blue dots that are at the top of the chart. And these speckles are going to analyze the three main types of contractility that every single ventricle or the left ventricle undergoes on every single beat. So we have these three types of contractility, not just this way, which is how shortening fraction measures the function. So we have the radial contractility. So the heart comes from the outer to the inner, and it contracts that way. We have the longitudinal contractility, where the heart squeezes from the top to the bottom, it gets together. And we have the circumferential contractility of the heart. And think about the phenomenon of squeezing a wet towel. So you have in opposite directions, so you can get the water or the blood out of the heart in a much more efficient way. The speckles, or these different segments, analyze changes in the size and the deformation of the walls of the ventricle and generate an average number, a value. And think about 19 as the cutoff from normal. So the higher, the better. This is the way that the results look at on the echo machine. And when tracking these different segments that are located on the left side of your screen from different angles that we analyze the ventricle, the computer makes a representation of all these different segments into this bullseye plot and generates a number, which in this case, in the lower right side of your screen, you see a GLS 22%. So that is the average of all these segments. And as I mentioned to you, the higher the number, the better, and 19 being the cutoff normal. So this is normal. What is the clinical significance of this particular technique? So in 2021, one of the largest trials using strain analysis, the SUCOR trial, that was a 331 patients international trial, prospective, very well organized. And so what the investigators had as a question was, if we use strain analysis to initiate cardiac therapies, are the patients going to do better when compared to initiating therapies based on an ejection fraction? And so this was a positive study. So they found that the initiation of cardiac therapy based on strain reflected less cardiac toxicity than the initiation of therapy based on an ejection fraction. So this is, again, good evidence that suggests that strain imaging can be very helpful in this particular set of patients. We've discussed this. We have many types of different cardiovascular diseases. Perhaps heart failure at the top of the iceberg, as I mentioned. Therefore, it's important to incorporate multidisciplinary teams and approaches. With this slide, I'm just including common types of CT-RCD on the top row, and on the second row, or the middle one, this is another paradigm to organize all these diseases. So at the top, you have the diagnosis. In the middle row, or the second one, you have methods to diagnose and provide surveillance. And on the bottom line, you have all these therapeutic options for each of these diseases. So this is a way to group all these particular diseases rather than memorizing, for example, what medication is going to cause what. And with this particular highlighting color in yellow, what I do is just showing you which ones are the type of cardiovascular diseases that scare me the most and that I put more attention. So with these previous slides, making different groups of diseases, I presented to you a framework that groups into what type of diseases, what type of diagnostic tools, and what can we do to manage those diseases. The framework that I'm presenting with this particular slide is a functional classification to stratify the severity of the patients. So all across the patients, how are they doing? And in this particular and broad approach into these 4 different groups, we have stage A, those patients who are at risk to develop cardiovascular diseases, and I consider everybody. So everybody's going to receive therapy, so everybody's at risk. And we focus in this particular set of patients on primary prevention. What are those comorbid factors that we can balance or mitigate so the patients are not going to get into the disease? And then we have stage B, patients who are manifesting cardiovascular toxicities, but they have not developed symptoms just yet. In this particular set of patients, now we're going to one may consider the initiation of medical therapy, but this is going to be not primary prevention. This can be considered secondary prevention. Stage C, as you can imagine, is the presence of cardiovascular diseases now manifested with symptoms. And the aim of this particular set of patients is to, with the management of medical therapy, to get back to stage B or stage A, where they're not manifesting, so we can reverse or ameliorate any type of cardiovascular disease. And as you can imagine, stage D is comprising those patients with advanced cardiac disease or refractory cardiac disease, and for that, what I would recommend is a hospital-based management or healthcare. So again, we group the different diseases into types, and then we group all the patients into the severity. And in my mindset, I'm thinking, so this is the type of disease, but the patient is in category C or D, so I need to start, spinning the wheels to see how I can reverse and help my oncology team. It's important to talk about anthracyclines because it doesn't matter, as I mentioned earlier, whether you're an oncologist, cardiologist, nephrologist, we're going to come across adversity. And these are medications used for a wide variety of cancers, leukemia, lymphomas, sarcomas, and so forth. So much that they are on the World Health Organization's list as an essential medication. And you know better this than me. You know that the cutoff recommendations for cumulative doses of anthracyclines have decreased over time based on odds ratios to cause cardiomyopathy. So back in the day, in the 1970s, the group of the MD Anderson Baylor College of Medicine followed 300 and plus patients, and they said, well, from the guys who are developing cardiotoxicity, most of them are with more than 550, so that was set at the cutoff in the 70s. Then in 2003, it came down to 400 based on the inclusion of echocardiography now to monitor these patients. And my colleague at St. Jude, Dan Mulrooney, in 2009 said, well, the odds ratio for the development of cardiomyopathy exponentially increases when we are reaching the 250. In clinical practice, let me tell you my story. I do see cardiotoxicity whether it's the first dose. So sometimes monitoring is going to be very important rather than an epidemiology or a statistical fact. So we also know that anthracyclines work or affect patients on a timely fashion. So we have the acute days, we have subacute months, and then we have the long term, which is years to decades. But it also affects the patients from the small to the bigger, right? So we have the organelles that are affected, we have the cellular damage, and then we have the entire system or organs. So the muscles of the heart, the myocardium is not the exception. And we do see in a summary 3 main findings. It's a lot, but in summary, I can talk to you about 3 main findings that we see how anthracyclines affect the function of the heart. So number 1, you have on the right the sarcoplasmic reticulum. This is kind of going back to high school, but the sarcoplasmic reticulum is essentially the organelle inside of every single cell that releases a significant amount of calcium, so the contractility is going to happen in that muscle fiber. And that sarcoplasmic reticulum is impaired, therefore the contractility or the systolic function or the squeeze is going to be impaired, therefore the ejection fraction is going to decrease. Number 2, we have impairment in the function of the mitochondria. Therefore, the energy is going to be depleted, and energy is significant. ATP is significant. It's require higher doses to relax the heart after the contractility. So it's an energetic process that the heart's, in order to relax and have a better diastolic function, they're not going to have the adequate substrate. So we have systolic and or diastolic dysfunction. And then the third one that I was just going to touch base briefly is the beta adrenergic receptors on the left kind of lower corner. And we do see an out of proportion sinus tachycardias many times in these patients and or the development of any other tachyarrhythmia. All right, so third myth versus reality. Anthracyclines do not cause any harm unless they reach a certain cumulative dose. So false. I just talk about it. So anthracyclines are very versatile chemotherapeutic agents used for a wide variety of cancers, but they are associated with cardiotoxicity even at low doses. Surveillance and risk factors modifications are important in order to decrease cardiovascular events, and early detection and early timely management results in better outcomes. So the last two subsections of my presentation. So how can we provide protective strategies? So this is a slide that proposes just very broad, very simple things, but they're very important when it comes to take care of these patients on a daily basis. So nutrition, and nutrition is very important for the heart to have adequate function. We have adequate nutrition. Electrolyte balances, so help us with having all these electrolytes within their range. I know it's a lot of moving targets with these patients, especially when they're sick in the ICUs, but mitigating the derangement of electrolytes help us to mitigate the burden of arrhythmias and cardiac contractility issues. Beta blockers, there's a lot of data that, and I'm gonna talk a little bit more about beta blockers. The same with ACE inhibitors, plus minus diuresis. And then this is a very controversial topic, the use of pressors in the patient in population in the oncology patients. So a lot of these patients sometimes develop shock. Let's just name it shock. And the shock, to this day, I have not necessarily seen cardiogenic shock. What I've seen is septic shock a lot. And what I've seen is a distributive shock because the patients are very vasoplegic because of this endothelial dysfunction. They don't have a tone. It's not the heart. The heart may be affected, not to the point of not generating an adequate cardiac output. Therefore, I think it's okay and just okay to use the rescue medications like epine or epi-dopa and dobuta. They're going to give you some sort of establishment of the systemic vascular resistance good enough to provide supply to the organs down the road. But the long-term maintenance of these medications are actually going to be, they're actually going to deteriorate the cardiovascular system. And this is proven. Hours to days, these drugs just give us a worse outcome. So we have instituted and changed the mindset of using, if we need blood pressure, and if this is a vasoplegic case, then vasopressin. And if we use a little bit of support for the heart, then why not using calcium chloride as an infusion? Because the calcium is impaired at the level of the organelles. So if you provide the substrate, the hearts are gonna contract better. And the analogy is you have a very old car and the engine is breaking apart. And you don't have gas. So the harder you push on, then it's gonna go faster until it doesn't. And typically these hearts, when you push them, after receiving all these therapies and after having sepsis and after being vasoplegic, epine or epindobuta tend not to give us the best outcomes. Debatable, but it has given us a good outcome. Other protective strategies, dexrazoxane. So you know this better than me. It's a heavy metal chelator, and it reduces the toxic radicals in the body. This medication, dexrazoxane, has been approved as a cardioprotective agent in women with breast cancer. But I have seen a very fast and growing body of literature, mainly from Eric Chow from Seattle and many others, suggesting that there is a short and long-term benefits from this medication in the pediatric population. Another landmark study from dexrazoxane. This one is a little bit older, and this is from Steve Lipschultz, where he demonstrated that the use or the incorporation of dexrazoxane decreases the serum levels of troponin. Troponin being a biomarker of myocardial injury. So if you look at this chart, on the horizontal axis, you have time expressed by months, and on the vertical axis, you have the levels of troponin. So what you can see is that the group in red only received doxo, and the group in blue received doxo plus dexrazoxane. And suffice it to say, the levels of troponin are much lower. Therefore, we presume that the myocardial injury is much lower when adding dexrazoxane. This is information derived from a lot of randomized adult trials suggesting that slow infusion rates rather than boluses in the administration of anthracyclines help to prevent the high and acute accumulation of anthracycline. Um, I would think that with not a lot of robust data from peds, I would encourage just communication between teams. When feasible, the use of alternative formulation of anthracyclines should be considered. The liposomal presentation may be efficacious and less toxic for the heart. And then we do have robust data when it comes to the use of beta blockers to help to mitigate cardiac dysfunction in children and adults with cancer. Carvedilol, perhaps the most studied medication within this group of medications. I really like it. It's perhaps the medication that I prescribe the most. And briefly, carvedilol is a non-selective beta blocker. Boom, pharmacology, first year of medicine, right? So carvedilol, what it does is that it works a little bit on your vessels, so it decreases the blood pressure, but it also helps to mitigate the tachycardia, so it decreases your heart rate. This is the analogy that I use sometimes to explain why lower heart rates and lower blood pressures improve cardiac function. I'm not an athletic person by any means, but if I'm going to compete to, a basketball player or Tom Brady, well, when Tom Brady was like a superstar, if we both jump into the treadmill, the only way I'm going to keep up with an elite athlete is if I slow down my pace. Under the eyes of a judge, we both are exercising, so there's no debate about it. But if I try to keep up with his speed, I'm going to get tired. Therefore, the hearts. If I slow down the pace or the heart rates, then chances for that heart to become dysfunctional are lower. And we publish that. Blood pressure. So the same phenomenon, I am with The Rock or Arnold or Tom Brady at the gym, and we both are bench pressing 300 pounds. I'm not going to give one of those reps, and they're probably going to go for 10 reps. The only way I'm going to keep up to exercise in front of the judge is if I get rid of the dumbbells and I just do the barbell. I am exercising, but the heart is pumping under a less stressful environment because I'm lowering the blood pressure. The pressure the heart needs to overcome in order to move move the blood forward. Um, the second most studied beta blocker is metoprolol. It's a selective beta blocker. Boom, again, pharmacology. But what it tells you is that it decreases more the heart rates than the blood pressures. Though any beta blocker blocks the renin pathway, PKPD, and so most of them are going to decrease blood pressure, but metoprolol works a lot more in heart rates. So depending what is the profile, I tend to use one or the other. There are a lot of trials using ACE inhibitors, and they have shown that these medications promote early recovery in adults and children with by decreasing the blood pressures, just the phenomenon that I explained, and a little bit of a voodoo, but they're supposed to have some antioxidant effects as well. So the last section, future directions. With this one, I really hope to see the incorporation of advanced imaging, strain analysis, cardiac MRIs, in pediatric trials studying cancer drugs. I think that the better we delineate the cardiac disease, the better understanding we're going to have for the profile of those particular medications in trials. The second topic here is that I would like to open an invitation to participate with us in the International Cardio-Oncology Society. I am the chair for this particular group, the pediatric group, and I am extending an invitation to nurses and oncologists and any patient advocates or anybody else who really want to advance the field of cardio-oncology. We actually did a webinar 2 months ago or so. We have monthly activities, but our webinar back in November reached 46 countries. We have subcommittees now of patient advocate and education and imaging. So at the end of my presentation, I'll display my email, and if anybody is interested, please. The last topic here as future directions is the fact that as a cardiomyopathy cardiologist, as a physician looking into the muscles of the heart, I've been always intrigued by the genetic background of CTRCD. So we completed our pilot study last month, and we used a systematic genetic approach to understand the genetic and the molecular basis of CTRCD by combining phenotypes, genotypes, so how the heart's looking and acting, how the genes are acting after the exposure of these drugs, and we use omics data from animal models. And just share briefly, because I know everybody's tired. So, and I'm very passionate about it. I can keep talking for hours. But three main results. After anthracycline exposures, all the mice decrease the skeletal mass. So the weight of those animals decreased significantly. So, and then we look at so because of that finding, we look into their hearts. And what I'm showing you here is the delineation of the heart's perimeters, and at the bottom, the delineation of the same heart after the anthracycline exposures. And this is a very interesting finding. So although you can see that the bottom heart has thicker walls when delineating the ventricle, the overall left ventricular mass indexed to the size and body of the mice decreased. What it means? What it means is that after exposures of anthracyclines, the muscles or the entire hearts became smaller. Not only that, there was a significant degree of swollenness all across the walls of the heart. So diastolic dysfunction, the heart cannot accommodate the same amount of blood. Therefore, the it's to react with tachycardias. And at the end, because of the muscle mass, we identify a significant degree of fibrosis. So I do believe that the exposure to anthracyclines, what it's giving us is just aging in our cardiovascular system. And then the most important finding from our animal models is the fact that we identified 4 candidate genes associated with cardioprotection based on the omics data that are summarized in these Manhattan plots. You don't really have to understand these ones. But what I'm trying to say here is that the 4 genes that we identified were genes that, after receiving the anthracycline exposures, trigger molecular mechanisms to say, hey, we're going to protect you. And so I think that this is going to be interesting moving forward, because maybe one day we can modify the genes of our patients to have better protection. And with that, one more. So cardio-oncology. I should have started with this one. It's a very well-established discipline that not only has set the foundation to screen, prevent, or treat, but it has also formed the partnership with many other physicians, oncologists, hematologists, intensivists, infectious disease, to provide comprehensive care and improve the outcome. Survival for pediatric cancer patients has improved. Well, I guess this is my summary. And this achievement is being by the incorporation of newer modalities in managing cancer and the approach of supportive care from different disciplines. And I think that ultimately, as we continue to work together, we will shift the paradigm, managing late and advanced cardiovascular disease to prevention and wellness. And with that, I would like to say thank you, and I'll be happy to take only gentle questions.
Thank you so much for that wonderful talk. I have a gentle question for you. Um, a couple of things you mentioned really resonated with me as an oncologist. One is that dexrazoxane is a great drug, and 2 is that there's no safe dose of anthracycline. Or maybe you didn't say that exactly, but reading between the lines. One thing that's bothered me at our International Consortium, the Children's Oncology Group meeting, is there seems to be a shift towards reserving dexrazoxane for patients who get more than 150 milligram per meter squared. And I don't understand the rationale. Is there a reason not to give dexrazoxane to lower
From the
doses?
very beginning?
What's that?
From the very beginning?
Yeah.
Yeah, it's a very good question. I think my bias is that this medication is underutilized. I think it should be given to everybody, period. I think there were some concerns about the refractoriness of, the management of cancer, therefore we're not going to use it. But Dr. Chow from Seattle has shown robust data on how this is beneficial, and the recurrence of cancer is not different. At St. Jude, for reasons I don't understand, what we're doing is if the patients are programmed to have more than 250, we're going to use it, but not in those who are expected to receive less than that. So, time to do another trial.
Well, welcome to the land of dextroxane administration.
So, from a hematology standpoint, a lot of my interest is in transfusion and toxicity from transfusions. And so, common practice, and brand new kid with leukemia, they're going to be in the office for these spot visits, and you're giving anthracycline that day, and the hemoglobin's a little low, and you don't want them to have to come back for a whole week, so you top them off with blood, or they're coming in overnight for Cytoxan Adria, and you top them off because you don't want them to have to come back for a week. And there's so much free iron in these blood transfusions, and all the organs have to, suffer from that. Is that being looked at? Is that a bad strategy?
Yeah, we've done some studies, not necessarily in cancer patients, but those with sickle cell that also are prone to receive lots of transfusions. And there's a lot to say from our results showing the iron deposition affecting the cardiac contractility, both the squeeze and the relaxation. So the inclusion of advanced imaging modalities like a cardiac MRI has elucidated how frequent transfusions promote iron deposition, not just the liver, because everybody was just looking at the liver. And then we scanned a little bit higher and we said, oh, the hearts are also affected. So there's that downside. The downside of anemia was studied back in the 80s at Baylor College of Medicine. So what they did was animal models, they were exsanguinating it and observing. The hemoglobin is 10, 8, 6, 4. They went all the way down to 3, and then they were scanning the hearts. This is 1990. And so what they concluded, and again, this is a very old study, but what they concluded is that the threshold for the heart to develop pathologic remodeling, meaning it's changing, it's about 6. And they call it a high output heart failure. The heart has to work so hard and so fast that it's impeding its function. Uh, Again, very old study, but the cutoff of like, oh yeah, we should probably transfuse was 6. I don't think that's the cutoff. I think it's, yeah. But I mean, there's also a lot to say about transfusion. I think in the past we transfused a lot, and I think we have mitigated that because of the adversity as well.
Yeah, there we are. So about heart. So, I mean, obviously in HEMONC, I mean, we've got multi-system dysfunction and organ toxicity from all the chemo and the rest of the modalities. And I mean, we do think heart is probably one organ that we probably don't tend to pay that much attention until it's too late. And part of the reason probably is, I mean, we've got monitoring for kidney, liver, and all those things that we monitor on a day-to-day basis in terms of labs and everything. And we just don't have great biomarkers for cardiac dysfunction. And all we have is some imaging modalities, and we're still sort of struggling on it. So in terms of dexazoxane, is there any data? I mean, obviously there's cardioprotection that we already know, but how about the vascular, the decrease in the vascular disease later on, because that's also a main reason for ischemic heart disease for our patients.
So you're asking if DEX has an impact to some degree in the long-standing period for the vasculature? Okay, that I don't know. With all honesty, I don't know if we've looked into do the patients in the long run that use DEX have less degree of fibrosis, therefore hypertension in the, in the media of the layers of the vessels? I'm not sure. Maybe I'll have to look into it. Um,
So we have found this more recently, I would say in the past year of ordering echoes in the past ordering echoes in the past year on most of our patients, and we've gotten back this feedback of shortening fraction is stupid and, why are y'all even measuring it anymore and blah, blah, blah. We're doing it because our protocols, per Children's Oncology Group ask for shortening fraction and ejection fraction. And so we're seeing now more this whole longitudinal strain. So what are the good numbers of that, I guess, per se, since this is something new for us on the echo reports of how do we know what a good longitudinal strain is?
Yeah, it's a lot of numbers when you look at the report.
Correct.
It's not like the EF,
Right.
boom, one,
Right.
two digits, right? So it comes on
Yeah.
a lot. But from the three main different types of strain, the global longitudinal one, it's the one that has come up with more reliability when looking at oncology patients, period, across different studies and across different vendors. Because we have 2 to 3 major vendors here in the US, they have different cutoffs when it comes to normal values. But you're not gonna get it wrong if you look at just the absolute number, because it comes in a negative and a number. You're not gonna forget about the negative. When you look at the number, if it's 18 or higher, so 20, 21, 25, the higher the number, the better. And I would say 17 to 19 is the gray zone, depending on the vendor. I don't know what vendor we're using here. I don't know if we're using strain. Okay.
Single vendor, and it's very different between inpatient and outpatient.
Yeah.
I will say our reliability on strain imaging through the general cardiology clinic, that is much better. Most of your patients are coming through the hospital side of things, which is why, Hugo coming will be great, but likely some of those clinics, it may be better to run through our general cardiology because of quality. There is a better way to streamline.
Yeah. So what I would just put attention, if you want to look just at a single number, it will be the average GLS, and look at the number.
Well, and I think most of us are trying to get our patients in through the clinic downstairs and get our echoes through there. And I think some of it just has to do with availability, right? But I think for the most part, we are trying to use y'all's clinic more for those. So hopefully that will help some. And so since you're leaving St. Jude, maybe you can get involved with COG and help reframe the protocols asking for these cardiac function numbers in your spare time.
Don't, yeah, don't get me started.